In the following podcast, we'll discuss shortness of breath, specifically asthma exacerbations in adults. Before we get started, let's go over a bit of pathophysiology review. There are three major components to asthma: airway inflammation, bronchial hyperresponsiveness, and reversible airflow obstruction. The pathophysiology of asthma begins with inhalation of an allergen, which causes production of IgE. The IgE binds to airway mast cells, which release inflammatory mediators, histamine, leukotrienes, and cytokines. These cause bronchospasm, airway edema, and airway eosinophilia. Remember, chronic asthma can result in permanent airway remodeling. So what can cause an asthma exacerbation? Common triggers include allergens and irritants, weather changes, emotional stress, medications such as ASA, NSAIDs, beta blockers, exercise, and respiratory infections such as viral URI or pneumonia. Let's look at a case. Mr. Smith is a 34-year-old male who presents with complaints of shortness of breath and states that he thinks he has a cold. Rhinorrhea for the past 2 days, cough for 3 days. He's tried using his home inhaler, however, he states that he doesn't feel like it's helping. He reports no fevers, no chills, no nausea, and no vomiting. Remember to get a complete history, including your old cards or OPQRST, onset, anything that makes it better or worse, quality, radiation, severity, and timing. And get a quick review of systems. For all asthmatics, there are a few important questions to ask. How often do they use their inhaler, previous intubations, hospital stays in the last year, and recent steroid use in the last year? The patient's answers will give you an idea of how bad their asthma really is. Only one steroid use in the last year, and they only use their inhaler once or twice a month, well, that's not so bad. But if they've been intubated before or have had many steroid bursts in the last year, that's a little more concerning. Next, you should get a good physical exam. Always check out the vital signs first, and pay attention to the respiratory rate and O2 saturation. For our patient, Mr. Smith, his heart rate is 98, BP is 140/89, respiratory rate 24, temperature 37.8, and O2 saturation is 92%. Next, you should do a general exam, paying specific attention to the respiratory exam. How tight are the patient's lung sounds? Are they moving air well? How wheezy or stridorous is the patient? Are they having to use any accessory muscles to breathe? How long is their expiratory phase? Remember, all that wheezes is not asthma. You should also consider CHF, upper airway obstruction, foreign body aspiration, COPD, CF, vocal cord dysfunction, and bronchitis. For your immediate interventions, start by placing the patient on oxygen. Your goal is to get oxygen saturation over 90%. You may also want to get some medications going. Your choices are albuterol versus levobuterol, MDI versus nebulizer, ipratropium bromide, which is used for the first 3 treatments. Typically, we order duonebs, albuterol and ipratropium for 3 doses. Depending on how bad your patient's symptoms are, you may want to order some systemic corticosteroids. Some good options are dexamethasone, solumedrol, and prednisone. Oral and IV delivery are equally effective. If you think the patient may have an underlying bacterial infection, you may want to start some antibiotics. Be sure to determine if this is CAP or HCAP and cover for your atypicals. If the patient is really struggling, you may consider magnesium sulfate for severe exacerbations. And the worst cases of asthma may require BiPAP versus intubation for respiratory failure. For your diagnostic tests for asthmatics, you obviously want to start with a chest x-ray. You don't want to miss a pneumo or pneumonia. If you can, order a peak expiratory flow, or PEF. This is the patient's maximum speed of expiration. A PEF lower than 100 is considered severe exacerbation. If the patient is altered or in severe respiratory distress, consider getting an ABG to help determine if intubation is necessary. These will constitute the main ED management and treatment. Disposition will depend on how bad your patient's asthma exacerbation is. Some patients will need a few treatments and maybe some steroids, will stop wheezing and feel great. Those people can go home. However, on the other hand, you may end up with a severe exacerbation requiring steroids, continuous DONEBs, IV magnesium, BiPAP, or even intubation. Those will obviously need admission. Disposition will often depend on your experience and which attending you're working with. This completes another podcast. Thank you for listening.